I'm Larissa Moniz. I am the Director of Research and Mission Programs at Fighting Blindness Canada, and I am going to be your host for this evening. Before we start, I want to acknowledge that we are in Toronto, which is on the traditional territory of the Haudenosaunee and the Mississaugas of the Credit First Nation. The land is also part of the Dish with One Spoon territory, a treaty between the Haudenosaunee Confederacy, the Anishinaabeg, and allied nations. And I know we have guests and community members from across Canada. So we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people from whom this land is home. So thank you everyone for joining us for episode 1 of Fighting Blindness Canada's Accelerate Vision Health series. This session is titled Bridging Gaps in Eye Care from Knowledge to Decision to Access. We're incredibly grateful to our partners for helping keep this national series going strong. And together we're shining a spotlight and sparking conversations about the key issues that are shaping vision health in Canada. We'd like to thank the following sponsors for making today's session possible. Our discovery partners, Bayer, Heathbridge Capital Management Limited, and Roche Canada. Our connectivity partners, Alcon Canada Incorporated, Amgen Canada, Astellas, and Dealey Group. And our access partner, Biocon Biologics. So tonight, I'm really excited to welcome 5 special guests where we're going to have a 2-part conversation about shared decision-making and healthcare provider-patient communication. First, we'll be joined by 2 professionals who will share their insights, and then we're going to hear from a panel of 3 individuals with lived experience of vision loss who are going to offer their personal perspectives. And then once we hear from all of these speakers, we're going to open it up for audience questions. So if you think of questions at any time, you can post them in the Q&A button at the bottom of your screen, or you can email us at info@fightingblindness.ca. So why are we having this webinar? I want to start by inviting you to think about how communication really shapes every part of the healthcare experience. From the first conversation that you may have with a healthcare provider about a symptom to potentially complex choices that you have to make following a diagnosis. And the way these conversations go can really determine if trust is built and impact a person's experience. I know that when we talk to community members about their eye health journey, some of the strongest memories they have either stem from very positive or unfortunately negative experiences with their healthcare provider. Part of the conversation is going to be about why is good communication and informed decision-making, why does that matter so much? So let's get started with our first panel. So I will invite Dr. Nimmin and Dr. Eamon to turn on their cameras right now. Welcome, both of you. Thank you for joining us. So Dr. Laura Nimmin is a scientist at the Center for Health Education, Scholarship, and is an associate professor in the Faculty of Medicine at the University of British Columbia. Dr. Nimmin is a social scientist and award-winning researcher whose work explores the social dynamics of power and shared decision-making. And we're really excited to have Laura with us because she's going to be bringing a broader perspective that includes other areas of healthcare outside of ophthalmology. And also joining us is Dr. Dave Eamon. Dr. Dave Eamon completed his medical degree at the University of Saskatchewan, followed by his ophthalmology residency at the University of Alberta and a fellowship at Wills Eye Hospital in Philadelphia. He currently practices at Alberta Retina Consultants at Edmonton, where he manages medical and surgical diseases of the vitreous and retina, and he is also president of the Retina Society of Alberta. So thank you both for joining us. Dave, starting with you, from your experience and your clinical practice, what are some of the biggest barriers patients face when they are making decisions about their vision care or their treatment options?
The biggest barrier that our patients face in terms of making decisions about their own care is just, number one, understanding what's going on. So typically, my group is a retinal subspecialty clinic. So patients get referred to us through a variety of avenues. They can come mostly from optometrists who they see in their community, who they have long-standing relationships with. Some of them come from our fellow ophthalmology colleagues who have diagnosed a specific retinal problem that needs our attention. Rarely we get referrals directly from family doctors. And then, we also get emergency phone calls from the emergency room if patients end up going that route. So patients get to us, through a variety of streams. And, once they get to our office, it's pretty quick. It doesn't take a lot to figure out what's going on. And as you mentioned, the point of this is just clear communication, educating them on what's going on and that we can certainly help, is the starting point. And then we do a lot of same day treatments in our office just because a lot of patients, our catchment area is so large in Edmonton. So a lot of patients are driving from significant distances. So I can imagine for a lot of our patients, it can be overwhelming to come in with a diagnosis and what you're going to put a needle in my eye right away here, what you're going to do a laser, what you're going to send me to the operating room today. Um, I can totally imagine how that can be overwhelming for patients and their caretakers, but that's typically how we do it. If they need something emergent in the operating room, we'll send them right to our local hospital. But if it's something we can manage in the office, we'll do same day treatments. And then in terms of, we don't really expect them to come with a good understanding of what's going on because lots of times the diagnosis is, could it be this, could it be that? Or it's just a general referral, sudden acute vision loss or gradual vision loss. And then it's for us to kind of tease it out and make the final diagnosis. So that would be my first comments on that question.
Okay. Yeah, I'm gonna throw it to Laura if you want to. Do you have anything you want to? I know you're not in clinical practice yourself, but from your experience, what are some of those barriers that patients might face?
Yeah, it's a great question. And just to remind everyone, the perspective that I'm sharing today comes from my research. So I've looked at how power and communication and relationships between healthcare providers and patients play out and how decisions are made and what kind of barriers come up. So even though ideas like shared decision making and patient centered care are valued, there's still always these sort of subtle relationship and systemic barriers that can make it hard for people with lived experience of a blinding eye disease to fully take part in decision making. So we know, it's indisputable, like healthcare providers do, and they should have power in their relationship with patients. So they have expert knowledge and legal authority to make decisions. And patients are depend on their healthcare provider to care for them and provide treatment. But how patients feel that power can affect how they feel free to speak up about their values, their beliefs, and preferences during the decision making process. So um, and power is sort of a construct, isn't something that we can always see. It's not necessarily observable. It's a kind of immaterial concept, but it does show up in the way that healthcare providers talk, the words that they choose, how they present treatment options, and how they approach the decision-making process. So, it can show up in how they listen to a patient and value the patient and their opinions and beliefs without judgment. And so I think one of the biggest challenges that patients face is not all healthcare providers are willing to share their power when it comes to making decisions together. So even in my research with very experienced physicians, I've asked them about how they perceive their power and how they share it. And they responded very differently. There are sort of three main categories of reflection from them. So one group felt they do have power and they talked about how they share it very ethically and mindfully. Another group felt that their power is decreasing because patients are so informed by being able to access the internet, for example. And the third group felt that there is no power. It's an irrelevant concept and it's sort of non existent, especially in this era of shared decision making. So, patients might face some communication challenges making decisions about their vision care treatment options, depending on the approach of their healthcare provider and their awareness of their power and how they manage that in shared decision making.
Sort of makes me reflect on my own experiences with my healthcare providers in different ways. I consider myself pretty knowledgeable about these issues, and I still know that when I'm sitting in front of my doctor, I very much defer. If they tell me something, I sometimes am nervous to ask a different question. And so I guess maybe a question going back to Dave, but also maybe Laura, is like, since you've become a doctor, Do you find that has changed your experiences with your own healthcare providers, or if you're like maybe a caregiver for somebody, and how you talk to healthcare providers, knowing the sort of the roles that are in play now?
As a retinal subspecialist, it's a high volume practice, so time is limited, and so the words you use and the way you communicate, it has to be very, very efficient. Um, but that being said, I mean, we're probably saying the same 10 things over and over on a regular day, and we have it kind of dialed in terms of what we feel needs to be um, delivered. But I think, we all realize that at the end of this, it's knee jerk and routine for us. The most important thing that I do, and I think all my colleagues do, is before we, move forward with the treatment, or before we, schedule another appointment, this was a lot. Do you have questions for me? And that's where you just kind of sit back, make good eye contact. Usually there's a caregiver in the room, so you might look directly at them to get them involved. And that's where a good communication session occurs, just to make sure that everyone's on the same page before we move forward. Um, in terms of how I, communicate with my other allied healthcare providers, it would be the same. We can chat a little more efficiently because the understanding might be closer. Um, and then in terms of taking care of, I haven't had that role yet.
I'm gonna go back to Laura for the second question, where we've already sort of touched on it a bit, but where the idea that at least traditionally, professionals have held most of the information. I think you touched on a very good point that nowadays a lot of us are coming into the doctor's office or our healthcare professional's office with a lot of information. So, how do you feel like we can make decision making more balanced so that patients can feel more informed? And do you feel like I guess the internet, for lack of a better word, has already started to make that happen?
A big part of creating a balanced relationship between healthcare providers and patients is, in some ways, rethinking the construct of shared decision making and even how it's evolved over time and where it's at now. So there's been different models that have sort of evolved over time. And of course, in the past, it was more of a paternalistic model where a healthcare provider makes most of the decisions and then holds a lot of the power in the relationship and in shared decision making. And there's also the consumer model where the patient is in control and makes the main decisions, although I think that's more rare. And I think what we strive for now in Canada and all around the world is this partnership model where the provider and the patient share power and make decisions together. And it's, I think, kind of a widely accepted definition right now, shared decision making. And so in this model, healthcare providers and patients work together to look at the evidence about treatments, and they talk about risks and benefits and think about what matters to the patient in terms of values, goals, and concerns. And it includes listening to the patient's experiences and concerns and building a real connection through conversation. Um, and so, in this kind of communication dynamic, healthcare providers are bringing expert knowledge to give to patients to access care. But to have a true partnership, providers need to do more, of course, than just share biomedical information. As I say, it's communication that's constructive is based on their tone, that their demonstration of empathy, and even their presence, and it really matters a lot. So we know that when patients feel cared for and understood and not judged, the relationship feels supportive and not controlling, essentially. And so the research shows that patients will stick to treatment plans, take care of their health, and feel like active partners in their care. So um, we need to remember, I think, that patients bring their own kind of power and influence to the clinical encounter in eye care, and things like the internet, researching the internet, which of course is so common right now, influences from family, from friends, community beliefs, culture, religion, and others in their lives really, really do influence how they engage in shared decision making. And I've argued in some of my work that that's a form of power. And so rarely, I think, in education, really, and in the construct of shared decision making, do we talk about these outside influences that influence shared decision making for patients. And so there's a bit of a gap there in our understanding. I think to truly balance the relationship, patients need to feel safe in sharing all these broad sources of influence that are influencing them. And it's surprising to me that in some research I've looked at, many healthcare providers haven't really been trained to how to talk to families or even ask patients about what's influencing their understanding of, you know, their disease or eye care treatment and wishes, and what are these outside sources of influence. And I think kind of harnessing that information in different ways is really important for truly balancing the relationship and shared decision making.
Going back to my clinic in our scenario, like we do give a lot of patient handout information sheets that they take with them. And I say, look, we threw a lot at you today. This is a lot to digest. Here's some reading material that you can, look into on your own, and feel free to call or ask questions that come up. And then we also have recently revamped our website. We find a lot more people, depending on the age and how comfortable they are using computer technologies, they do go onto the website, and we have resources from the American Academy of Ophthalmology and a variety of sources where there's really good material, videos, handouts that you can read or print off, for educational material for patients. The other thing I will say in our practice, in terms of decision making, a lot of the patients that get referred to a retinal specialist will have like an acute loss of vision. And so the discussion, it's usually pretty brief. It's like, well, we need to act pretty soon. It's like, so I'll give a couple of scenarios. So if you're referred with wet macular degeneration, you've all of a sudden lost your central vision, and hopefully you're getting into us within, a reasonable amount of time. And then the discussion, obviously they're nervous, they're scared, they're anxious, which is expected. The decision to treat or not to treat, it doesn't really come into play. Like, I mean, everybody comes to us because they want their vision fixed. So it's it's an acute decision, and it's like treat or no treat. And treatment means getting some vision back. Not treating means, the vision gets worse and potentially irreversibly lost. So that would be scenario one. Another one is like a retinal detachment. So if you come with a retinal detachment, you've had acute loss of vision. The decision is, well, we have to do surgery today or tomorrow, best case scenario. So, it does create a pressurized system for the patient. And, Laura would probably appreciate this, that, I think it's probably very difficult to download everything that a patient might need to make that decision. This is where they're really trusting the expert and the physician to do what's best for that patient, which is what we do. But it is very, very time sensitive. The third scenario where I think there's a lot more time and room is diabetic macular edema. So you have diabetic bleeding or swelling in the eye, in the retina, and the vision's starting to gradually deteriorate. So in those scenarios, if we deem it safe to potentially try lifestyle modifications, diet, exercise, tighter glycemic control, in those scenarios, it's a different approach, because it's not as time sensitive. We can try, altering the medications. We can try lifestyle, diet, exercise, and then follow up to see how that's turning out, to see if it's affecting the vision in a positive. And then if they come back and that hasn't worked, well then, it's time to treat, which is a kind of a yes or no decision there.
I also want to follow up, Dave, and get your opinion on something that Laura mentioned, which was about treatment adherence, like the idea that if you have a sort of a more informed patient, better communication, you might get more treatment adherence. So I guess thinking about once you've gone through that acute phase of you've got to treat right away because you've got like an imminent sort of bleed in the eye. And once you're at the point where you want patients to come back every month or every few months to be getting their injections, do you find that the conversations change a bit, or you have found certain ways to have the conversation to convince patients that actually you should be coming back, even maybe if you aren't seeing any more improvement, or even if your vision is still changing a little bit?
Absolutely. Like, our patients are lifelong patients. And so it's a continuous discussion that happens over weeks, months, years. And so, yeah, I mean, as treatment progresses, the discussion changes. Um, Fortunately, the drugs that we have to treat things like macular degeneration and diabetic macular edema work very, very well. So patients get the treatment and they're like, yeah, I'm seeing better. So the coming back um, thing is not really an issue because they realize it works. And the understanding is, well, this isn't a cure, it's a controlling agent. We're trying to prolong what you have and prevent further loss. So certainly the discussion evolves over time. And then, if we realize that the treatment response is not adequate, that's when we can start talking about other drugs that are available. And by then, a lot of people have done reading and they're asking about this drug and that drug, and are there clinical trials to get involved in? And then you go with the patient on that route depending on where they're at. So yeah, it's evolving relationship. It's an evolving conversation after the acute phase is established.
In healthcare, we sometimes talk about helping patients to stay independent and to have independence within their healthcare decision making. But your research is really also reminding us that we all sort of depend on each other. You've got patients, you have families, but you also have providers. So I was wondering if you could talk a little bit more about seeing care as that shared effort, and how does that change the way that decisions are made if you're seeing it as that sort of shared partnership?
A lot of the work I've done critiques this idea of independence in healthcare in general, and how it's a little bit of an illusion in terms of a concept. So we see it in so many areas. For example, how we train our healthcare providers, our students. Students are assessed on how well they work alone and without supervision. So the goal is to become an independent healthcare provider. But we know from research that this leads to a lot of problems like working in silos, poor teamwork, burnout. And in reality, successful healthcare providers rely on their colleagues for advice and support and perspective. And it comes up the concept of independence, and it's sort of the theme that runs through our conversations on patient-centered care is there too. So we talk about patient-centered care as if it involves the patient only. And we forget, I think, sometimes that patients are influenced by so many people and factors in their own lives that shape their decision making. So it's interesting sometimes to think about who patients see as part of their care team. It's not just health professionals like ophthalmologists and optometrists and family physicians and other sort of traditional healthcare providers. It can include dietitians and counselors, a massage therapist, a reflexologist, a family member, and research has shown that I've been involved in that patients rely on a much bigger, more diverse team than that we usually imagine in healthcare. And on these teams, as I go back to my interest in power, power is not just held by a physician, for example, it's shared. So power can shift depending on the situation, and even non-traditional team members can have a strong influence. This idea goes actually back to my doctoral work, where I studied how patients make health decisions and who they go to for advice. And I found that while they had like this deep respect for physicians, they also trusted friends or family or coworkers or people in their spiritual community. And especially if they perceived that person in their own social environment to be smart or trustworthy or have gone through a similar illness. So if we think of power as influence, then it's clear that many, social, cultural, and religious factors shape how patients think about their health and make choices. And patients are very rarely fully independent. They're part of a complex social and cultural network that really deeply affects how they understand and manage their health, and impacts how they make decisions, especially when when decision making evolves over time, as Dave mentioned. So my work really does highlight that patients don't make decisions alone most of the time. They live in these rich ecosystems of care and influence, and providers really need to be asking questions that reflect that reality.
Yeah, I really love some of those thoughts. Even the idea that like power, if you think about it being not just with the healthcare provider and sort of patient, but also with other members of their community or other people with similar experiences. We see that a lot in our community events, um, the information sharing and the support that people are getting from other people who've had some similar experiences and opportunities to learn. Yeah, just briefly, Dave, do you have anything to add to that, or about how you also work with your colleagues to sort of support each other in what are sort of busy and emotionally trying careers?
Absolutely. I mean, I could not do my job as a solo practitioner. It'd be very, very difficult for a number of reasons. I mean, opening up a clinic, getting the infrastructure is very, very costly. So I'm very fortunate to work in a group of like-minded subspecialists, Alberta consultants. So there's 8, soon to be 9 of us who, I mean, I'm in my office right now and we're in the back here and there's chairs. We call it chair time. We talk nonstop about personal stuff, how we're doing, which helps to prevent burnout and make sure we're all at our best. But we share about cases all the time because um, a lot of different pathologies come through our clinic. The majority of it is the bread and butter stuff that's pretty easy to diagnose, but every once in a while we call it a zebra comes through, and you might have an idea of what it is. And we do weekly rounds where we share cases just to make sure that the best diagnosis and the best treatment plans have been established for the patient. This is where the wisdom of 8, soon to be 9 of us can share and make sure that we're all doing what's best for our patients. So I would say, yeah, without that, I mean, it would be very, very difficult to have a long, successful practice. And similar with surgery, I mean, we operate every day, and there's always one of us in the operating room. And if one of our patients needs something urgent, we share with our colleagues, and that's just what we do. We all take care of our own patients, and we take care of our colleagues' patients when they need to get in an urgent time, and we're not there for X number of days. So yeah, a group practice model that we have is an absolute blessing for us, and hopefully for our patients too, because they might just be seeing me, but and only seeing me and hearing me. But the truth is, my opinion and our experience is a blended model from the collective group. So it's fantastic.
Mhm. Thank you. We only have a few more minutes for this session, so I'm just going to do a rapid fire with both of you about if you had either one thing you could change about how decisions are made, or practical steps that could help close maybe any gaps that are in between the communication between the healthcare provider and patient, so that everyone is having an optimal experience. Dave, I'll start with you.
I think you have to book your clinics at a reasonable pace. You have to be providing the time that's needed to translate um, to the patient what's going on, and making sure you're always building enough time into each patient interaction. I mean, my patients and our patients will tell you that they're waiting 2-3 hours for an appointment is not uncommon, and so we are aware of the time constraints because there's a limited number of specialists like myself. So yeah, we learn to be very, very efficient with how we get patients through our clinics. Being cognizant of their time, of their caregivers' time, who've taken time off to bring their loved one in for an exam. Changing things. I mean, there's a lot of things. So we have to keep in mind we work in a public healthcare system, and a lot of decisions that we um, abide by are made by government, and we're active, always chatting with government. Currently I'm the president of the Eye Physicians and Surgeons Association of Alberta. I'm the past president of the Art Society of Alberta. So there's always ongoing discussions with government. They're asking for our opinions as the subject experts, and usually that's a pretty collegial two-way flowing street, but not always. We don't always get what we want, or we don't always you know get what we suggest should be done. So we're always handcuffed to a degree, and then we have to be stewards of the system. We have to be, conscious of resource allocation in terms of costs, because everything we do is very, very costly. Um, so that's something that's never going to change, and you just have to learn to work effectively in that system.
That makes a lot of sense. And Laura?
I think in medical education training, health professions education training, which is where my work is really situated, is from an educational perspective. Medical students and health profession students, I think they could be trained to just quickly ask patients like what kind of influences they have in their life that are shaping their understanding of their health condition, and their experience of blinding eye disease, and sort of creating with them like an influence map, maybe, which is a visual representation or a list of people that shows who they go to for information and what's influencing them, to sort of build that communication with more empathy and curiosity. And I think it's just a bit of a pivoting from seeing the patient as just an individual in isolation. I think some other kind of quick, easy, like these are not things that take up a lot of time, is to maybe have the patient call a trusted person during the appointment if they're not able to make it. Encouraging patients to bring people to future visits. Healthcare providers can write notes with clear explanations and questions for the important people in the patient support system. And then also focus on growing the network of patients for adding in more support. So, of course, connecting them with community groups and recommending peer support programs, referring them to other healthcare professionals. And I think all of those things are really important for seeing patients living within this bigger support system. And, the other tip I have too is just to always center the relationship. So sometimes patients, they disagree, or they don't adhere, or they're not, understanding the information in the way the healthcare provider is hoping for, and it can bring frustration. But I think always just focusing on the relationship and the trust that's been built, and not trying to always control patients if they're not adhering and they have different resources that they're gathering information from that are maybe misconceptions of their health. I think it's the way that healthcare providers respond to that with compassion and curiosity, trying to understand and always trying to preserve the relationship rather than being sort of combative, I guess, which we know from research can have a really detrimental effect on the relationship.
I want to thank you both for participating in our first part of our panel. So we will be moving on to our second panel shortly, but we will be calling you back in for the question and answer at the end. Before we bring on our lived experience panel, I'm going to take one moment to share a few words from our discovery partner, Bayer.
Bayer is proud to be supporting Fighting Blindness Canada's Accelerate Health series as a discovery panel partner. At Bayer, we're committed to supporting initiatives that foster education, innovation, and dialogue in vision health. This important series is helping to advance conversations around eye health, research, innovation, and patient advocacy across the country. We invite you to join the conversation. For more information about the series and Fighting Blindness Canada, you may scan the QR code here.
Thank you very much to our discovery partner, Bayer. As I mentioned earlier, we will be inviting your questions at the end of the second panel. I can already see there's a question in the Q&A, so feel free to submit questions using that Q&A button or by emailing us at info@fightingblindness.ca. So now we're going to call on three wonderful individuals who each bring their unique experiences with vision loss to join the panel. So Sandra, Mary Kate, and Alexis, if you can put on your videos and take yourself off mute, we will get started with the second part of the discussion. Before we get started, I just want to introduce each of our wonderful panelists. We have Mary Kate Fraser, who is based in Ontario. She's been involved with Fighting Blindness Canada since 2018. She was diagnosed with retinitis pigmentosa at age 20 and has been an active member of the FBC community, including through our Young Leaders program. She is a project management professional in healthcare who earned her Bachelor of Commerce from Carleton University. And Mary Kate is also passionate about the arts and staying active through yoga, interval training, and indoor cycling. We also have Alexis Nickerson. She is from Halifax and is the mom of two busy athletic teenagers, one of whom also has retinitis pigmentosa. She works as a physiotherapist in the areas of complex pain and prenatal care. And she and her son play a Paralympic sport for the visually impaired called goalball. She also enjoys rock climbing with her family. And last but certainly not least, we have Sandra Niedermeyer, who is from Calgary and holds a master's degree from the University of Calgary. She enjoyed a professional career with the Calgary Board of Education, retiring in 2002 as principal of CBE's first school to offer an arts-centered learning program. And since retiring, Sandra has been fortunate to travel extensively and pursue her interests in the performing and visual arts. And while she's experienced vision changes due to age-related macular degeneration and geographic atrophy, she's hopeful that ongoing research will continue to improve outcomes for others. So thank you everyone for joining us. So we heard from Laura and Dave about some of the ways that they communicate or some of the ways that potentially healthcare professionals can enhance communication. And so I want to just sort of put it out there that after hearing from both of them, was there anything that really stood out to you, or did any of their ideas reflect or challenge your own experience of navigating eye care? I don't want to put anybody in the spot, so if you want to speak up, please put up your hand. Okay, Mary Kate.
Sure. Thanks, Larissa. Good evening, everyone.
Mhm.
I noticed that Dave started off the conversation with saying that the number one challenge that they face is just patients understanding what's going on and having an eye disease, particularly a rare one. I can definitely relate to that sentiment. And then I reflected on what Laura said about that difference in power imbalance, and it just made me connect the two and understanding that there really is such a difference in the knowledge when you're the patient and you're talking to someone who's an expert in that area. And having said that, I'm so grateful that there are people who are passionate about science and medicine, because I'm definitely not. So it's as much as you look to these expertise there, I just reflected on the fact that there is that there's that kind of power imbalance when it comes to the knowledge of what's going on with me versus what they can see in their imaging and their tests. And so I find myself kind of overwhelmed in these situations. And then after, not just in ophthalmology, but in other areas of healthcare, you kind of go home and you start Googling things, or you start trying to do your own quote unquote, air quotes research, or using chatbots and that kind of thing to kind of understand the gaps. And I think it is just because as Dave mentioned, it's such a high volume area of the healthcare system that we only get a few minutes. And what's also what also impacts that is the fact that there's only a few minutes, but particularly with an IRD specialist, you might only see them once every 6 months, a year, 2 years. So you only have a few minutes, and then you're trying to also cram as much questions as you can into a couple of minutes. And so it makes me reflect on that kind of tone and empathy that Laura was talking about, and how that empathy coming across really, really makes a difference when it's it can be such an emotional time and such a short interaction with a healthcare professional, and having that tone really helps kind of build trust with your healthcare professionals.
Obviously, partly it's the information, but the tone and feeling sort of supported is also, it sounds like, equally important in that relationship.
Laura mentioned sometimes in her research, she sees healthcare professionals can maybe come off as controlling or combative. I would also add, especially when you have a rare disease where there is no treatment for it, it can come off as dismissive, because there's nothing they can do for you. There really is no next steps with RP at this point, hoping that changes one day, but there is no real treatment option. So sometimes it can, and I know they don't mean it, but it can come off as dismissive. So when I do interact with ophthalmologists, optometrists, anyone in the healthcare industry, when I just have that kind of understanding that this is a difficult condition to live with, it builds a lot of trust.
Yeah, I think something that might, follow what Mary Kate just said, and I think Dave spoke about it as well, is really the right information at the right time. As you said, Larissa, my son and I both have RP. And, I can remember clear as day the day he was diagnosed, and I was essentially diagnosed right after. I remember thinking, I have all these emotions and I just need to keep them at bay because I need to ask my questions. I'll feel this later sort of thing. And I feel like our specialist really did it. It was perfect if I look back on that now, even at the time. Um, I mainly want to know what it was, what was the future going to look like. Um, what is there any treatment? Is there any cure? And when we got that diagnosis, the appointment was just with myself, which was also, perfect. My at the time 9-year-old, she said, don't bring him, and it was great advice. And even the advice of when I asked, what do I go home and now tell him, was great as well, along the lines of, answer all his questions honestly, but you do not need to go home and tell him today that he is, going blind. So I think that right information at the right time is so important, and I'm sure it's really challenging to know for specialists how much information do you give, but I felt our experience was, in a really hard situation, pretty perfect.
That's really wonderful to hear. I've heard a few really good experiences, and we've also heard from other community members who, in both the AMD and the IRD space, who get a diagnosis and yeah, feel sort of like Mary Kate is saying, sometimes a bit dismissed, maybe because there aren't treatments, and so their sort of experience, or maybe because you're one of many patients, or they haven't, they're old school doctors, who knows what the situation is. So it's really wonderful to hear some positive experiences. And Sandra, did you want to add anything to that discussion?
I will, and it relates to the first question you're going to ask, and also Laura's comment on power. I was diagnosed with my macular degeneration and wet after I'd had surgery for my cataracts. And luckily, I had a wonderful doctor who did my cataracts. So he immediately referred me to a doctor very quickly, which was good. However, the doctor did really want power. And so when I came in to meet with him, I already had done a little bit of research, yes, through the internet. So I had names of the different types of injections that were possible. And I wanted to discuss a few things with him. And he immediately pretty well dismissed that and said, this is what I use. It's cost effective. And that's all there is to it. There was no discussing it. And he also said, and you need to realize you are going blind. So that was just almost too much for me to take. And I thought, I'm not going to be able to work with this person. So luckily, I went back to my doctor who had done my cataract surgery, and I said, all right, I've talked to some other people who have got the same situation as I have, and they have a wonderful name of another doctor, and I would like to be referred to that doctor. And luckily, it took me a while, but I was referred, and I'm now with a doctor who takes the time to listen to me. Yes, as Dave mentioned, there's often long waits, but I'm willing to wait for him in that waiting room because I know when I see him that I'm going to get my questions answered. We're going to be able to discuss things, and he has empathy. So it's now a positive story from a negative.
Oh, that's really wonderful. And I feel like we're going to be touching on the same themes again and again, the tone, the empathy really coming out really, really strongly here.
I think the other thing is that I think people need to realize that it is really important for each of us to advocate for ourselves. And that's so important. And I think people sometimes hesitate to do that, thinking, I'm not a doctor, I don't have that training. But I think we have to stand up for ourselves.
I'm going to ask Mary Kate or Alexis. I'm thinking about that, advocating for yourself. Is this something that you're comfortable doing, either for yourself or for Alexis, for your child, or is it something you've learned to do? Like, I guess, where are you in your journey along advocating for yourself in healthcare? I would say I don't feel like I'm very good at it yet, so I'm going to put myself out there saying that's something I know I need to do better at.
Yeah, I think so. I think what really helped. I do feel like we're my son and I are actually both. I feel like we're both pretty strong advocates for me, for I guess both of us. My son for himself. And I think what really set the stage for that was that initial appointment and diagnosis, to be honest. We were given information around gene therapy trials and how to stay current with what was happening. And so, once we kind of digested the diagnosis and information, I immediately started looking at trials and having a little bit of background in healthcare myself. I encourage my patients as well to advocate for themselves. But we started doing research, reaching out directly to centers with clinical trials, asking our questions, and really not being hesitant or afraid to do that. Um, so I feel like we're both very comfortable with that, but I think our specialist has really helped set the stage for that and given us, the right tools right from the start with that.
Yeah, that's wonderful. And Mary Kate, how about you? Where do you feel you are? Are you comfortable with the amount of advocacy you feel like you have confidence when you're having an appointment?
It's definitely been something that I've had to learn. It's now been 13 years since I was diagnosed. I was diagnosed at 20, and I definitely I had the mentality that you just listen to the professional and you do what the professionals tell you to. But in this case, there really was no next steps. It was essentially wait for science to catch up, and one day maybe we can schedule in for a treatment. So that left a lot of space for me to explore the advocacy world, especially through Fighting Blindness Canada, especially meeting young leaders and meeting other people who are in our 20s and university and working age who are dealing with the same things I do. And I've definitely learned more from my community at FBC than I've learned anywhere else when it comes to advocacy. So I am getting better at it and learning to understand that time, even though it's short, it's still my time when I'm with a healthcare professional. I think it's sometimes also easier if you're in maybe like a private setting when you're getting other types of healthcare that you're paying for. But if it's a public setting, it's still your time and it's still your time to use with your healthcare professional. So definitely been a learning curve since I was 20, but definitely getting better at it. And also encouraging, other people in my life when they have a diagnosis, whether it be eye related or otherwise, encouraging them to do the same that I've had to learn over the past 13 years.
Sandra, I'm going to come to you next to ask about any challenges. You sort of talked about it a little bit, but I don't know if you have other things you want to talk about kind of challenges you faced in getting either care, treatments, or information you needed, and what helped you overcome them. Or for people, I'm going to move on, if you haven't felt challenges, some of the things that the healthcare providers did that helped your journey go smoothly.
Okay. I think one of the major things was the fact that now I'm with a doctor who really will talk to me about everything that I need. And that's really, really great. The second thing is I ended up going to 2 conferences that were put on by Fighting Blindness in Calgary. And I just found those so informational. Not only the sessions that were given, but also the other I don't know what you would call them, but you had booths with everyone who were talking about different things. There was the athletic part of it. It was everything. It was your whole sort of life. And that was really, really beneficial for me. The other thing I'm finding is I have a couple of friends who are not necessarily with macular, but with vision problems. And I'm finding the support of peers in those situations is very, very beneficial. I have one friend right now who is legally blind, and she just introduced me to the Meta glasses. And I just thought, oh, this is really quite neat and something I might like to try. And so I think, again, it's that what Laura talked about is that there's a whole community. And also through Fighting Blindness, I met another lady, and she and I have talked about both of our situations.
So Sandra, have you tried the Meta glasses yet?
No,
Okay.
yes, no, that's not true. I tried hers. So I
Okay.
haven't tried them myself, but I
Yeah.
tried hers, and I was totally amazed.
Mhm.
And unfortunately, on Thanksgiving, I don't know, I went from Thursday, I was fine. And during Thanksgiving, I lost a whole bunch more vision.
Oh.
So before that time, I didn't think maybe I needed the Meta glasses. But now I'm looking at, oh yeah, they might be very, very handy.
Okay. Well, I'm sorry to hear that, Sandra.
Well, it is, and because it's the geographic atrophy.
Mhm.
And if there was one, I think Dave mentioned this, if there's one area that we would love the government to do more on, is more research and more sort of things that can be done for these particular problems that all of us have.
Absolutely. Alexis, I'm going to ask you a similar question about either challenges you've faced in getting to care treatments. I know you mentioned being interested in clinical trials, or some really positive associations you've had with your healthcare providers.
Yeah, so I think, and Laura, so I think you mentioned complexity within the healthcare system as well. And so we did, I shouldn't say we traveled, my son and my husband traveled for 2 years for a natural history study to the US with hopes of there being a clinical trial at the end. Um, and to add further complexity, it was at the height of COVID. So 2020, he traveled to the US 8 times in 2 years. And then when we started looking into the clinical trials, we had a lot of questions. So we had done our initial research. We had the wonderful support of our specialist locally. But these trials are they're so complex. So while you can do your own research, um, our specialists supported it, the group, the research and the science behind it. There's so much to learn. So we had, navigating that complexity, it can be challenging, but we had many calls with the team that were going to be testing our son for a trial to make sure that all of our questions were answered. So in great detail. And I can still, we looked up a bit about kind of risks and benefits, which are so, so important to know. And there's so many of them. And I would say the last time we did this, my son was 15, so about a year ago. And, while the risks and benefits may have seemed kind of minimal to us, we got off one of those first calls. And, he had been so excited and he goes, I'm out. What does this mean? I'm going to be hemorrhaging from my eyes. And, just taking that moment to pause and stop and explain, and then also having the team explain. Because he, of course, for anyone that does or doesn't know anything about clinical trials, at that age, he fully needed to consent to everything. So he had to have a great understanding. It didn't matter if we wanted it for him or not. It was up to him. So I think really, taking the time to have those conversations is so important, and understanding, for something like that in its entirety and as fully as you can.
And that does sound really complicated and is interesting, because almost in this position, you're holding a lot of that sort of information power potentially. I know he's a, a very sort of invested individual as well, and is, I'm sure, doing a lot of his own research. But yeah, it's interesting to think about the power dynamics in a whole different way as well.
Absolutely. And I should say, once the it was explained to him that he wouldn't be, hemorrhaging from his eyes. He was fully on board. Unfortunately, it didn't work out in the end. But for anyone wondering, he did not get to go through with a gene therapy trial, at least yet.
Okay.
But it's important, you never know what someone's going to be thinking about a potential risk. That was a surprise to us when we got off that first call.
Absolutely. Absolutely. Um, and yeah, moving on to Mary Kate, sort of similar question about challenges that you've faced in either getting care or information and what sort of helped you.
As I reflect on the challenges in getting information, I remember when I was first diagnosed 13 years ago, I was sent on a myriad of tests, imagings all over downtown Toronto. I think I hit almost every hospital in terms of equipment, and letters to specialists. And I remember going through a lot of tests and images, and I honestly, I couldn't tell you the name of any of them. I couldn't tell you what they were for. I couldn't tell you any kind of result, whether they were good or bad on it. And, as I reflect over my years, I have to prompt myself, not just in ophthalmology, but in other areas of the system, because I find the healthcare system really only tells you something if there's an action after the fact. So it's really prompted me to ask the questions. And sometimes it's tough because if it's a technologist, I understand that they can't always give you the information on the spot, but always following up and understanding, what was that test? What was it for? What does it mean? Because there's also the situation of when you go to different healthcare providers and they start asking you about your history, I don't always have the information to give them because I actually don't know a lot of what I was tested for and what the results were. So in terms of getting challenges of information, it's besides, a general, okay, everything looks good, really prompting the question and understanding, what does this actually mean? Where do I kind of stand in the grand scheme of things? And I know RP is a very hereditary or heterogeneous disorder. So understanding what does my condition look like, and sort of prompting and kind of pulling the information out of healthcare providers, even if it doesn't actually result in a tangible next steps for treatment or care delivery.
So yeah, being sort of really proactive in your questioning,
Yeah,
because it's true, you're not, there's limited time, so not everybody's going to offer all the information or know what information you maybe particularly want to hear.
exactly. I remember in particular, I think might have been at Sick Kids, but we went through this whole color test and they were showing all these different colors. I was naming them and then they started to get grayer and grayer. And I was starting to tear up because I thought I was losing my color vision. I asked the technologist, I said, what color is that one? He says, oh, that's gray.
Okay.
But I didn't know because they weren't giving me any sort of feedback. So you kind of build up the story in your head if you're not being told what's happening, right? Yeah.
Yeah, absolutely. So moving on to, I think, our final question for this session. I'm going to start with you, Alexis. It sounds like you've had some really positive experience, and so it would be actually great to know, what advice would you give to either eye care professionals or to maybe somebody else going through a similar sort of diagnosis as you did, about how to either better include patients or be better included in that conversation or decision making?
Yeah, I think it really goes back to, it is difficult to get to know how much and what information to give initially, especially on diagnosis. Um, but trying to make that right for each patient, which is probably going to be different for each patient. I think also, I know some of our friends and family were surprised, height of COVID, we're traveling for this study, and um, there was so many layers on that. We have another child and busy athletic child. I work full time, so height of COVID, having to travel and then come home and isolate for another 2 weeks. Um, there's no challenge or nothing we kind of won't do for our kids. But looking at that from the outside, that was really our decision. So I think my advice is maybe to healthcare providers, you never know what a patient or family will or won't do. Give them all the options because you don't know how far they're willing to go, or what they're maybe capable of doing, instead of um, I think I can say this in healthcare. Sometimes we think, oh, that, that patient won't want to do this. They won't want to travel for that. But, um, maybe they will. It was certainly a complicated and a lot of problem solving for us during that time, and but we knew we wanted to do it, but it was important that it was our decision.
Mm-hmm. And did you always feel like it was your decision to make, or did you feel like when you're having conversations with either your primary healthcare practitioner or maybe the people doing the trial that you were getting swayed one way or the other by them, or were they like very
Yeah,
much
I
the
think it really
information with you?
was. Yeah, I think it really was our decision. Again, I think, we've been very fortunate, and so I hope this is helpful. Sometimes it's more helpful when there's been challenges, but I think it really was our decision. We were given the right information. We knew it could potentially be a great opportunity, not only for potential um, gene therapy, but also in just helping to help advance science and research, and
Mhm.
and we were more than willing to be a part of that. So um, I think we had the right support and the right information without, any sort of bias one way or the other. Probably more bias from friends and family that might have thought we were a little bit crazy for doing what we did for 2 years, but
Thank you. Mary Kate, I'll go to you with a similar question about advice to either eye care professionals or to other patients.
I would say for eye care professionals, for me, I really benefit when I know as much of the layperson science as they can possibly give me. Otherwise, I'm going to Google it myself and I'll probably do it wrong. So I would say really gauging where the patient is at in terms of their understanding and meeting them at their level goes a really long way. I had an MRI for an unrelated issue that turned out to be normal, but the resident actually sat me down and showed me the images and basically gave me a one-on-one about how the brain works. And I walked away just feeling such a positive experience, because it also I think it showed like a level of respect for the knowledge that I had. So that was a really good positive experience. And then in terms of other patients, is get to know other people in the community, because you're going to learn so much from them. And it always makes me feel better when I meet people at FBC events and I can pass on the knowledge that I've learned over the past 10 years. So it can be a really isolating condition to live with. So getting to know people is always the best piece of advice I can give anyone, not just with eye disease, but any sort of experience with illness, injury, or anything with the healthcare system.
Okay, thank you so much. And Sandra, over to you.
I would echo what Mary Kay said as far as dealing with your healthcare provider, and also maybe making sure that your optometrist and your retina specialist are also fairly well linked. I found that has been very, very beneficial for me, that they are willing to go back and forth. As far as recommendations for other patients in the same situation that I'm in. One of the things that I learned from a friend of mine, she logs every time she goes for an appointment, she logs it in a diary, and she puts down what has happened, what the discussion was, and some information about that appointment. And I thought that was very beneficial. So I've started to try and do that. I haven't been the best at keeping it up, but it is a good idea. And the other thing is that before you go to some of your appointments, if you are, you're hesitant, or you're kind of, and sometimes I forget, you get in there and you kind of forget. So write your questions down on a piece of paper and have them with you, because that's really beneficial as well. And I think for me, the other thing that is so important is to stay social, because I find that a lot of people who have vision problems start to close their world in. And that really is so difficult then. So still go to the theater. You may not be able to see everything perfectly, but you can hear the plot for what's going on. So stay social as well.
I feel like that example was very personal, because I gather you love going to the theater, Sandra.
I do.
I do too.
And I now have to go to the ballet. When I go to the ballet, it's with my binoculars.
Okay.
And so I can see the costumes in more details. I can see the face. Yes. So do not give those things up.
A year, I think maybe the last couple of years, the National Ballet of Canada has invited FBC to bring some individuals to the ballet for an accessible performance. And in that performance, it was accessible for many different types of people. But this one, they also had audio description. So you could get headphones and it would describe what was happening on stage in terms of some of the ballet moves, but also the action, which I thought was really wonderful. And it's like, just a small step, but it was
That's great.
Yeah.
I'll advocate for that in Calgary.
Yeah, absolutely. Okay, so we're sort of wrapping up our second session. So thank you so much, Mary Kate, Sandra, and Alexis for sharing so many of your experiences, your thoughts with us. And I'm going to invite Laura and Dave to join us back on screen. Laura, I'll start with you. Was there anything that you sort of took away from that conversation?
I felt like some of the stories from Mary and Sandra really stood out to me of things that like their experiences are echoed a lot in my own research. So it was just interesting for me to hear their stories about, the importance of community and social support and finding a provider who's respectful and also in Sandra's case, taking sort of control and agency and finding a different healthcare provider by asking for a referral to see someone else. I think that has shown up in my research too, and that can be like a form of agency and kind of a way to respond to power when it feels really hierarchical. And so I really appreciated a lot of those stories. I have all kinds of notes. I love the example of the ballet and also Sandra, your attempts to still go to the theater with your friends and not self-isolate. Those are really beautiful examples. But yeah, I just really appreciate, and also I feel like sorry, I'm just trying to see Alexis. Your story stood out to me too about how it sounded like you wish to pursue these exploring the clinical trials, but folks in your community and social environment maybe weren't supportive. And so that stood out to me as kind of an interesting example of you may be working with your healthcare provider of a plan that worked for you, but maybe in this case, your own community maybe wasn't as supportive. So it sort of for me spun a bit how I think about influence and agency. So I thank you for that. But I really appreciate all of your stories and examples, and they're very interesting. So thanks.
Thank you. And Dave, I'll throw the same question to you.
Yeah. So thank you to all three of you for sharing your stories. I guess starting with Alexis, I mean, your point on don't assume that people won't spend their own money to travel and seek help elsewhere, particularly down south. I think it's, I think as physicians in Canada, we're so entrenched in being stewards of resource allocation and being conscious of the costs that our work brings to the taxpayer. So I will definitely take that away. I mean, I'm definitely guilty of assuming, oh no, don't bring it up. They probably are not going to spend thousands of dollars and move their family somewhere to the Mayo Clinic or somewhere down south. So I hear you and thank you for sharing that. I will definitely do a better job of that the next time I see somebody like yourself with IRD. So thanks for sharing that. We should not assume that people are not willing to spend their own money to see better. And just stepping back, you think to yourself like, that is such a good use of your money. Like why wouldn't you want to do that? So it's just mind-boggling that we didn't. So thank you for that. Sandra, thank you for, yeah, I'm sorry for your first experience. Like, I get it. Avastin is the cheapest. We usually start with Avastin first, and if it fails, then we go to the more expensive ones. Like, that is kind of, again, speaking on being conscious of costs. But, to deliver to that manner, like that's, yeah, we can and should do way better than that. And then, I mean, when I meet somebody with wet AMD for the first time, I mean, I would never say, and I never say, you're going blind. Like, I'm glad you're here. We're going to reverse this, and we're going to prevent you from going blind. So, yeah, I mean, that's just bedside manners 101. You know, we're trained to do that all the way through medical school. And, you know, I'm sorry that was your experience, but good on you for saying, no, this isn't going to be good enough. I'd like to see somebody else. And I'm glad that things have turned around for you. So good on you for not accepting, you know, that, because you've paid tax your whole life. Now you need some serious help and some expensive medications, and you deserve to get what you want. So good for you. Um, and then Mary Kate, yeah, again, like, guilty of ordering a battery of tests, an ERG, a Humphrey Visual Field. I mean, in Toronto, yeah, I guess it's at different sites. In Edmonton, it would be one site, but it is a lot. It's a barrage of treatments right off the get-go, some genetic testing, a genetic counselor, a lot that we throw at you because we think you might have an IRD. And then the patients are leaving Googling IRD, what is this? You know, and so again, I hear you and thank you for sharing that. I mean, it's, you know, we say ERG, it rolls off the top of our tongue, but of course you're not going to know what that is, or what the purpose of that test is to help delineate what we think you might have. And yeah, that would only compound a very stressful situation for you. And I could see that leaving you very feeling very powerless. And so yeah, I'm sorry that was your experience. And unfortunately, I think that's probably the majority experience for patients like you, Mary Kay, which you've probably heard now in your groups. And so yeah, we need to do a better job of just slowing down to explain those basic tests, which are critical. And unfortunately, we don't do them in our office. So it does mean more travel and time off work and time off school for you. So thank you.
Thank you for everybody. I just got one more question because the topic came up a few times with, I think, almost every speaker. The idea of sort of the interdependence of the different healthcare professionals working together. I know, Sandra, you specifically, I think, mentioned about you really appreciate when your optometrist and your specialist are working together. So just like maybe as a last question, if I can ask if you have seen this work well in your specific case, or for the professionals, how you try to connect connect with different healthcare providers for one patient. And I know it's very complicated in the healthcare system, but how that does that sort of work? Dave, I'll maybe start with you as a healthcare professional. Like, how do you sort of connect with either optometrist or maybe other allied health professionals around a patient and figure out what's happening with that patient and keeping track of that?
Yeah, for sure. So, I mean, most of us are using electronic medical records now, computers. And it's good and bad. It's bad because lots of times, and you guys can all relate, like, our back is sometimes towards you. And we're maybe talking into a screen and we're so focused on typing and clicking. And, you know, it does 100%, it takes us away from the patient. The plus side is it's very powerful in terms of click, send, update to referring doctor who's your optometrist. So from our end, it is not hard to keep our optometry colleagues in the loop, because the computer generates a report and it's sent out to whoever sent the patient there. So we try to do that pretty routinely. And I think, you know, anytime there's specific questions, Sandra, if you go back to your optometrist, like, hey, what did Dr. So-and-so say about this? They're very good at getting us either on the phone or sending us a letter. Obviously, the phone is the best way to get a hold of us because they get the answer right away. Unfortunately, sometimes the letters can take maybe a week to see, and that delays your answer, which can, you know, build anxiety. But yeah, I mean, you know, communication is huge. And then once we start co-managing, you know, say you're dry for an extended period of time, like, okay, you don't have to see me as often, maybe see your optometrist for an OCT every 6 months or so, you know, that's critical. That communication has to be there, because if there's any fluid, like, we need to get you back in right away. So yeah.
Okay, thank you. Glad to hear that electronic medical records are doing a good job somewhere. Alexis, how about you? Have you do you have a co-management situation right now with, say, a retinal specialist, optometrist, or other healthcare providers?
Yeah, we do. For both myself and my son. And I feel like it's been pretty seamless. Uh, Back and forth. We are in the process here in Nova Scotia of developing an electronic medical record, which rolls out soon. But so, however, they have communicated in our situation, it's been pretty seamless in terms of who's going to do what, who's going to look after what, for
Yeah.
sure.
And Mary Kate, how about you?
I've had the experience of not always understanding some of the interdependence that happens in the background. I definitely know that healthcare professionals work together, but sometimes when you're the patient, you're not seeing it. So you're trusting that's happened, but you don't always know where things are landing. I have personally had 2 referrals in my lifetime just get lost, and it's only when I followed up did I realize that they never made it. So recently I had to get a re-referral for genetic testing because my last couple tests came back inconclusive. And through Epic's My Chart with University Health Network, I was actually able to see the referral got sent. And so that was just a peace of mind for me. It wasn't communication, it wasn't any kind of interaction, but it was almost, just an electronic notification that it's in the system is really reassuring, I have found, because I've had the experience of things kind of going missing. So just some sort of documentation or acknowledgement that people are working together goes a long way.
Absolutely. I'm even noticing everything is more and more available to patients, which I think I think it's probably good and bad because you can get results of tests that maybe you don't know what they mean, and then you spend maybe time Googling for good and bad about that. So that's maybe not the best. But on the other hand, you do know when results have come in, and um, can take a bit more control over that.
I think there are some also situations where things do take 6 months or a year, and I can live with that at this stage, but just knowing that it's in the system really goes a
Yeah,
long way. Yeah.
absolutely. Laura, over to you.
I don't think we can assume that electronic medical records are functioning and succinct across every province in the country. And so I think one of the challenges when they're not very succinct is that patients end up having to remember information from each healthcare provider, and sort of representing the language and the terminology of each healthcare provider that they're interacting with, and then having to share that with their ophthalmologist or whatnot. And so it's very challenging. It places a lot of burden on patients. And so I like Sandra's tip about notes and kind of taking notes maybe when you're meeting with each healthcare provider, so you're not burdened with having to store all of that information in your memory, and also having maybe the healthcare provider write into your journal so that they're writing in notes if you are the one that is carrying this burden of having to kind of transfer information amongst your team. And there is no kind of electronic medical record, which I think is the case sometimes. So little strategies like that are helpful, or the healthcare provider, like Dave says, just calling up other healthcare providers for information. And then again, it goes back to my point that we need to ask patients who exactly is in their healthcare network, because who's the pharmacist that they see, like all these sort of different layers of information about who they perceive to be on their team. I think is important for really having truly succinct team-based care.
Thank you. And Sandra, I'm going to have the last word to you since you sort of brought the topic up sort of really, really clearly. So you feel like the connections between your healthcare providers is going well. Have you seen situations where you've sort of had to work at it, or other things like that?
No, I guess after my first experience, I feel like I've been blessed ever since.
Okay.
So my optometrist, when I ended up Thanksgiving weekend having this drastic change, I had called the office for my retina specialist, and they said, please go see your optometrist first. So I immediately made an appointment with her and let them know it was important. So I got in right away. She was wonderful. She looked at everything, did all the testing. She said, I'll send it immediately over. So it went immediately digitally. And then she said, but I also have someone in our office that worked in the same office that you go to with the doctor. And so she made them make a phone call. And then, to her credit, she phoned me the next, and then there was a weekend, and she phoned me on Monday to see if I had an appointment with my specialist. And, that's just caring.
Mm-hmm.
So it was wonderful. So that's what we need everyone to do, I guess, is what I'm saying.
I think we have to wrap up now, but thank you so much for everyone really giving your insight, your experience, and listening to the other participants as well. It was a really wonderful conversation. So I want to thank Alexis, Sandra, Dave, Mary Kate, and Laura. Thank you so much for joining us tonight. Our Accelerate series, it's a two-part event, and our next episode will be taking place on Wednesday, December 3rd at 7 p.m. Eastern Standard Time. And at that session, we're going to be diving into the important topic of vision loss and mental health. So I really hope you'll join us again. And once again, a big thank you to our Accelerate event sponsors for their support in making these important conversations possible. Our discovery partners, Bayer, Heathbridge Capital Management Limited, and Roche Canada. Our connectivity partners, Alcon Canada, Amgen Canada, Astellas, and the Dealey Group. And our access partner, Biocon Biologics. And finally, if you would like to support Fighting Blindness Canada's mission, we have a QR code up on the screen, which will only be up briefly, or you can visit us at any time at fightingblindness.ca. To end tonight's episode, we are going to be showing a video sponsored by our discovery partner, Roche Canada, which I hope you'll enjoy.
Marie has seen so much in her life, but what she didn't see coming was wet AMD. The blurred lines, the dark spot in her vision, the medical appointments that take away from the moments that matter most. But with all of the beauty in the world, she still has so much left to see. There are solutions that can help. Even with wet AMD, vision can continue. Talk to your ophthalmologist about your options. Roche.